So over the last few years, we have developed several genomic classifiers in the space of ER-positive and HER2-negative breast cancer. And those classifiers were designed to predict risk of distant recurrence. And in addition, what we found through years of research was that some of them also predicted for other endpoints, for example, benefit from adjuvant chemotherapy, benefit from extended endocrine therapy, in addition to their prognostic value. So all of those classifiers, which are now commercially available in the US and worldwide, mostly were designed, again, for risk of distant recurrence. And they have different levels of evidence. They're not necessarily classifying the same patient in the same category, so there is variability between the tests. So typically we look at, obviously, they all have very good analytical validity. In other words, they were very scientifically developed, and when you order the test, you're going to get a number which you can trust of what it means. But they have also different clinical development. Some of them were able to be developed in retrospective, prospective studies, and some others also have now information from prospective clinical trials, particularly when it relates to benefit from chemotherapy, which is essentially the important therapeutic decision that you need to make for these patients. One, you need to tell them what is their prognosis, give them a number, 5% risk of recurrence, 10% risk of recurrence. But the second is, would that risk change if you add chemotherapy to endocrine therapy? That was sort of the holy grail. And we were able to answer that for some of those genomic tests by doing prospective clinical trials that essentially have shown that for the low-risk patients, particularly with the recurrence score, the 21-gene recurrence score, and also with mammoprint, you don't have benefit from chemotherapy, particularly postmenopausal patients with a low or intermediate recurrence score, particularly for non-negative patients as well as patients with 1 to 3 positive nodes. But in premenopausal patients, we noticed that we do get some chemotherapy benefit. And now the next question that we're trying to address is whether this benefit is direct tumor killing cells, tumor killing from the chemotherapy, or whether it is an indirect effect of ovarian function suppression. Because what chemotherapy does in premenopausal patients, it decreases the ovarian function and eventually ablates the ovaries for the later postmenopausal patients. So these are the questions now we're trying to address in another prospective trial in the future.